The 100-year-old Gothic stone church, now home of Ocean Way Recording Studio, hasn't been a place of worship for 45 years. But by many in music, it's considered holy ground. Since 1995, the former church sanctuary now serves as a modern recording studio, hosting country acts like George Strait and Luke Bryan, pop acts like the Spice Girls, and a favorite destination for film and video game scoring. In healthcare, new payment models are hitting our airwaves. As the pandemic proves to be a catalyst for change, our new song is Value-Based Care. Nashville is a mix of music's past, present, and future, blending with healthcare in perfect harmony. So, for our final duet, we'd like to welcome to the stage Brad Smith, Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation, and Emad Rizk, Chairman, President, and CEO of Cotiviti.
Good afternoon, everyone, and thank you very much for joining us for this afternoon panel session between myself and Brad Smith. I hope you had a good morning with the morning sessions, and we will finish up the day with a conversation between myself and Brad about the future of value-based reimbursement and alternative payment models. And we have with us today is Brad Smith. Brad is the Deputy Administrator and Director of the Center for Medicare and Medicaid Innovation. Brad, thank you so much for joining us.
Thanks for having me.
And for many of you, I'm Emad Rizk. I'm the Chairman and CEO of Cotiviti, an analytics company in healthcare. I hope we have a good conversation today, Brad, but obviously when we talk about anything right now in healthcare, it has to start with COVID. I wanted our audience to really get an understanding of how we responded to COVID, but really focus our conversation around these alternative payment models and how they've been affected with the pandemic and how they've been accelerated and what is required by the industry to really prepare for these alternative models. So can you give us a little bit of perspective first around your organization and what its main mission is and how it responded to COVID, and then also enrolling things out with alternative payment models?
Yeah, for sure. So, I moved up to DC back in January to be the director here at the Center for Medicare and Medicaid Innovation. And that's the part of CMS that focuses on launching new payment and care delivery models. After I'd been here about 2 months or so, I got pulled over to the White House to help with the COVID response, and probably spent the majority of March and April kind of assisting with the COVID response. And then since probably May, have been splitting my time half and half between COVID and between CMMI. I know we're mostly going to focus on CMMI, but maybe I'll make just a few comments about COVID and then move to the alternative payment piece. But I think, we've come a long way in the 8 or 9 months since I started working on COVID. Obviously, we're having a pretty significant increase in cases right now across the country. But as I think about where we are today versus where we are in March or April, it really is night and day. In March or April, we had very limited PPE supplies. And what we've seen over the past 8 or 9 months, thanks to the efforts of the federal government and many states and private sector entities, is huge increases in PPE. The federal government is sitting on a much larger stockpile of PPE than we had 8 or 9 months ago. Many states have 30 to 60 days of stockpile in the warehouse, and many hospitals and other providers are also stockpiled. On the testing front, we've come a long way. Obviously, no test for COVID existed back in January or February, and obviously not been around before. But now we're at a place where the capacity for testing in the United States is probably 3 or 4 million tests a day, and probably about half of those tests are point of care tests. Now, we're not doing nearly that many tests. We're doing about 1.2, 1.3 million tests a day, but really, again, night and day in terms of where we were on testing back in March and April and where we are today. In terms of therapeutics and vaccines, we've also made a lot of progress. We've seen the mortality rate decline substantially in certain populations, including the elderly, over 75% since back in March and April. That's a result of better treatment in the hospital, therapeutics like remdesivir. We had a huge announcement this morning, maybe a few days later by the time this plays, but Pfizer announcing that their initial data from their vaccine trial is 90% efficacious, which is, much higher than any of us thought it would be. The bar was really 50%. And so, as we look out a couple of months from now, I think people are very optimistic about where we're going to be on the vaccine front through Operation Warp Speed. But as we go through this next 2 or 3 months, I think that therapeutics are going to be very important. I think mitigation efforts to decrease the spread are going to be very important. But again, when you compare now to where we were in March or April, I just think it's night and day difference kind of being in the middle of it. That said, while COVID's taken a lot of my time, my main job.
Brad, if you don't mind me interrupting 1 second around that, because it's really important for us to recognize, I think a lot of times because of just the hyperpolarization that exists in the world right now, we don't stop and actually look at the efforts that you've just discussed and that the federal government has discussed in terms of preparing when we did not have a test for COVID. To I believe right now we've surpassed about 150 million tests that were done.
Yeah.
Which is just phenomenal, for our country in terms of just identifying these patients early. But also the therapeutics originally in March and April and May, we had a mortality level that was, a fatality level that was well over 7, 8, 9%. And right now, even though we have obviously that second surge, it seems that the fatality percentage still is in the 1 to 2% due to the therapeutics and due to us understanding the disease better. And I think as I sit back multiple times throughout this whole pandemic and talk to other co-workers and co-leaders around this, we are in a very different place right now in November than we were in March and April, thanks to your effort and CMS and HHS.
Yeah, well, thanks for those comments. It's obviously been a huge effort across both the government and the private sector. And I think, not only are we in a really different place, we've also learned a lot, right? When we started, we weren't sure who was most at risk, et cetera. And we've learned a tremendous amount about that. When you look at the mortality rates, look, if you're above 70 and you have comorbidity, there's still a pretty serious mortality rate from COVID. It's higher than a couple percentage points. But if you're in a different demographic, whether it's below 40 or even below 70 without comorbidities, very low mortality rates. And that was things that we didn't know back in March or April. So, hopefully we're in a place where folks can understand their relative risk if they do get COVID, but they can also understand the mitigation efforts. But I do think, in a political season like we've just gone through, you're always going to have a lot of polarization and different opinions in terms of communications. But I think when you look at the actual work that's done, I think you're going to see a lot of consistency on the work that we've done this year and the work that will be happening next year.
I agree. I just wanted to make sure that that us and the audience take the time to thank you and many of your colleagues for your service, because there's been a lot of advancements that sometimes have not received the same recognition because of just where we are. But moving on to alternative payment models, and something that we've been talking about for years, for decades, as a matter of fact, and I would love to get your perspective on it.
Yeah, for sure. So when I got up here pre-COVID, one of the things that Seema Verma, the administrator of CMS, asked me to do is, it was the 10th year. This is the 10th year of CMMI. And so she asked me to go through and kind of look at all the models that we have done over the past 10 years to see kind of in aggregate, how have they gone? What have we learned? So we've launched about 54 models over the past 10 years. And as I went back through that, I think we've had some really great successes. Number one, we've had incredible participation in the model. So we've had about 26 million Americans in one of our models. Over about 500,000 providers have participated in one of the models. And, if you go to any conference like this one, folks are talking about value-based care. So I think in many ways, we've seen the whole dialogue around value-based care change over the last 10 years. When CMMI got created, the original goal and the purpose of value-based care was really to try to achieve one of two outcomes, which was either lowering cost or improving quality. And so as we go back and look at the 54 models, and we don't have evaluation results on all of them, but probably on the vast majority of them, I think we've probably learned a lot. So only 5 of those 54 models have shown statistically significant decreases in cost. None of the models have shown statistically significant increases in quality across all the different measures they're measuring. And some of the models on one measure for a couple of years, you might have an increase, but we haven't had a model where you said, wow, quality is demonstrably better kind of across the board. Now, it never gets lower, but very few examples of where it's sort of increased demonstrably across the board. And so as we kind of were able to step back and kind of have that perspective, we said kind of, why is this the case? Is this the case because value-based care doesn't deliver these outcomes, or is it the case because of a number of technical issues? And I think the answer is we don't fully know, but what we really identified was a number of what I would describe as technical issues that I think end up being extraordinarily important for the success or failure of some of these models. So maybe I'll just kind of mention a couple of them and then we can dive into some of them a little bit more. But the first is around benchmarking. So benchmarking is essentially the target price that we set for a population or for an episode of payment. And for our models to work, that price has to be accurate. And I think what we found is for lots of reasons in many of our models, that price has turned out not to be accurate. Some of that is many of the times early on when we were setting prices, we would talk to lots of folks in the field. We would kind of get their advice on how we would set prices, and then we'd build the price based on that. I think what we've learned, especially over the past 12 months or so, is the importance of using data to set the prices. And we, before we roll out a new model, should be able to run an analysis to say, hey, without this model, but if we go back and apply this benchmark, we should presumably not see any savings because the model wasn't running, right? It's kind of an obvious principle to somebody in business that you would test the benchmarks analytically, but that was something that was actually not happening robustly. And so that's something we've implemented this year. And again, I think it's some ways a small change, but a really important change for a number of the models. The second is to get CMMI up and going, we made almost all the models that we've had to date voluntary. There's a few exceptions, but in general. And I think voluntary is very good because it allows folks to choose when they want to participate in the model. The flip side, especially when you create lots of options for models, is you can end up with some weird selection effects and some adverse selection occurring in the models. And we've seen that adverse selection occurring in a number of our models, especially in our bundles model. It's called BPCI. It's one of our biggest models. We made a number of changes this summer to kind of fix that. And the third issue I would say is around our quality metrics. And, we have metrics that we track, and then we have quality metrics that we incentivize and pay for performance on, and we have metrics that we evaluate quality on. And one would think that those metrics would tend to be aligned, that the same things we're talking about in the model are the things we're paying on or the things we're evaluating on, but it actually turns out they don't line up as much as one would think. So we looked at a number of our models, we only had about 25% alignment between the things we were paying on and the things that we were evaluating on. And again, I think that's a technical issue, but it dramatically affects kind of the success of the models, I think, on some of these important metrics.
It's kind of interesting, Brad, because when I think about this, many of us have been around healthcare, for decades. When you look at those 3 categories, and you look at the benchmarking, and you look at the actual access to data, in the center of a lot of this, and maybe the second one was the volunteer versus, potentially sort of an opt-in versus an opt-out perspective. But it's very interesting that at the juncture of all of these 3 main sort of underlining opportunities is data. Is the access to data for benchmarking, is the access to data for quality metrics, is the access to data for potentially identifying risk. So you almost cannot really speak about a lot of the alternative value-based reimbursements without sort of the role of data, the role of interoperability, the role of understanding the population at risk, understanding the measurement and the quality metrics that you're going to measure to move forward, and to really what that outcome is, and to measure that outcome and make sure whether it's not how it compares to a benchmark. What are your thoughts around kind of how that connects to data and interoperability and the access to that data?
Yeah, I think data, just like you said, is extraordinarily important for all the models that we're doing, and honestly for policies beyond just CMMI at CMS.
Correct.
But I'll kind of start with CMMI, then maybe go a little bit broader. I think at CMMI, we have tried over time, and I think the team's done a great job of increasing the amount of data that we're both using in our models and providing to participants, but we can go a lot farther. So just to give you an example, if you look back 10 years, for somebody in our model, we were providing them, very, very little data, maybe no data to start, right? And then we started by providing them, spreadsheets of summary data. And then we kind of moved to providing them claims data, but maybe with like a month lag and only for paid claims, not pre-adjudicated claims. And where we're trying to move now is to where we can share data through an API. In one of the new models that we're working on that we might talk about later, we're going to be setting up an API feed so that within a day or two of claims hitting a MAC, that participants in the models can have access to that data. And so we think the more data that we can get to our participants, the better off we're going to be. I think especially when it comes to quality, the types of data that we're able to use is a big question. So historically, really the main form of data we've had has been claims data. And so the only things we're really able to measure from a quality perspective are those things that are captured in claims data. I think as you see connections between exchanges, information exchanges, and as you see the electronic quality measures that we're starting to collect, we're going to be able to do much more robust things in terms of testing the quality of our models. So we're really excited about that. And then I think even when you step up one step back, even beyond CMMI, the president and the administration has been very committed to opening up data access.
Right.
We finalized a really large, I think one of the biggest changes in interoperability in a long time. Obviously, the prior administration made significant investments to get folks onto electronic health records. And then I think the next step that this administration took was really trying to connect all of those electronic sources of information so that it can be shared more freely. And I know with the anti-blocking requirements that go into effect next year, we're really optimistic about the kind of impact that'll have on the system.
Do you, as you look at these 54 models, and so we've experimented ourselves also, and we kind of came up with all the value-based reimbursement, and many of us, and I think the audience, many people have experience with that. We looked at that and we actually found that we had gaps in data. So we would be able to identify the population that you want to go at risk with in terms of risk stratification and trying to appropriately get that. You don't need just claims data. You also need claims data and clinical data, potentially demographic data. So we tried to get data from all sorts of different areas because just claims data gives you just one lens to assess that level of risk. What are your thoughts in trying to get a lot of different types of data coming together to be able for us to do this? And then sort of, you mentioned it in the beginning of your talk, Brad, was how the public and the private sector came together, to respond to COVID. And as a member of the private sector, and we really did the best that we can. We worked with all the different electronic medical records. As you remember, we were able to leverage the early indicator of where the breakouts are going to be. So I've never truly seen the private sector come together as much as I've seen it this past year. Really, all the CEOs in healthcare, we've all came together. We put a lot of our competitive perspectives, aside for the better good of the country, and we worked really well with HHS and CMS. I really think this is a model for any administration moving forward, whether it's right, left, or whichever, to leverage, because there's a lot of key learnings. So just two questions around that. Number one is, what do you think of all the different types of data besides just claims that are going to be required for alternative payments? And then second is to talk about what's the role and how we can prepare from a private sector and a public sector to work together.
Yeah, so maybe I'll start with the public-private sector. So, first, you and so many of your colleagues were just incredible partners for us over the course of the whole year, but especially in that March, April, May timeframe when we were all together figuring out what to do. And the way that you all brought data to the table, the way that we saw the distributors come together to help us fly over PPE from Asia, the way that we saw the hospital systems respond, the insurers, it was really, I think incredible. And I think, if we can keep some of that spirit, I think it provides a lot of optimism for the future and what public-private partnership can look like. I think on the data front, obviously the more data you can get, the better. I think, we have, because we're trying to inform and change the entire payment system, at least for Medicare and in many ways for Medicaid, right? We also have to be realistic in what's possible. And
Right.
so I think in a number of our models, we understand that, really what we have access to is claims data primarily. And so, we have to figure out how to make that work in the best way that we can. We are also receive some other kinds of interesting data that we don't leverage a lot today. Things like MDS data and OASIS data that's in a standardized federal format, but that we're not kind of fully utilizing. And then also in our models, especially the models where we're carving out large amounts of risk, either to provider groups or to other organizations, we really believe that they can be the hub that pulls a lot of that different kinds of data together. It might be claims data from us, but it might also be data from their providers or other kinds of data that they're able to ingest. And so I think, the more data that we're able to provide, we'll definitely do that. But I also think as we delegate risk, some of those folks we're delegating risk to may be able to even bring together more data than we're able to bring together.
I completely agree. And what we did as just to tell the audience, there was all the payer organizations and payer vendors and all of the providers and also the supply chain organizations all came together to work with HHS and CMS to really put together a lot of the data and getting everyone to really be prepared and to share openly with HHS. I personally have been in healthcare for a really long time, Brad, and I would tell you that I've never seen the level of cooperation that took place. So now, how do we move forward? So we have a few key learnings, I think, based on what you said. And again, I really think that the amount of work that you, CMS, and HHS did, and I'm going to keep pushing that because I just don't think there was a lot of recognition of the work that was done. It really set a standard for how we work together in a bipartisan way and across both public and private sector. So as you look forward right now in the next 1 to 2 years, and what can we leverage from what we learned in COVID, and what can we look forward to in terms of alternative payment models around what they might look like, and also what's the timing of something like that?
Yeah, for sure. So maybe I'll speak to COVID and then come back to the alternative payment models. I think on COVID, we're not done with that journey, right? There's definitely a couple of chapters left in that journey. And I think the public-private partnerships are going to be really important, both in usage of therapeutics and in vaccine distribution. On the therapeutic front, if some of the monoclonals get approved, they're still going to be in somewhat limited supply, and working together to figure out how we target the right patients most efficiently to save the most lives possible is going to be critically important across the public and private sector. On vaccine distribution, again, that'll probably ramp up at a larger volume over the next couple of months as we go. But the distribution is going to be a very big public-private partnership. We already announced some of the partnerships with some of the retail pharmacies who are going to be distributing the vaccines, especially to places like nursing homes and assisted living facilities. So I think, the next chapter of public-private partnership will probably be, in many ways, based around the COVID therapeutics and the COVID vaccine. But I think on alternative payment models, we have pressed forward really hard this year, even in spite of COVID. We launched back in March a payment model around lowering the price of insulin to $35 in a number of Part D prescription drug plans. We launched a model back in September that we call the CHART model. It's around rural healthcare transformation that allows a number of different waivers from things like hospital conditions of participation and other things like that to allow providers in rural communities to really transform how they deliver healthcare. So, for example, you could take a small, struggling rural hospital, and if you wanted under this model, convert it into an outpatient department and an ER, for example, but still maintain some of your inpatient reimbursement rates. And then we have a few more models that we're working on trying to get across the finish line before the end of this year. One of them we call our direct contracting geographic model. What it really does would give providers, sophisticated providers or payers, responsibility for a portion of the Medicare fee-for-service beneficiaries in a geographic region, and then to be able to bring together providers and care management and lots of tools to really provide additional support folks in that region to be able to hopefully lower costs and improve quality. And we have one more model coming down the pike that, again, hopefully we'll get across the finish line before the end of the year. That's around duals and allowing managed Medicaid plans to take risk on the Medicare fee-for-service side for duals that are currently not aligned to the plan. And I think what those last two models show is what a lot of what I think we learned from the last year or the last 10 years and some of the analysis we did, which is if we can find big chunks of risk and if we can carve it off to people in upside and downside risk arrangements with fair benchmarks, we think that then gives those entities incentives and the ability to really transform how they deliver care by leveraging more data like we were talking about earlier, but also bringing providers together in different kinds of ways. And so, hopefully those bigger models where we're carving out more risk in bigger chunks will prove to be successful, but time will tell.
Yeah, and as we wrap up, I think one last thought, I would be remiss if I don't ask of it, and maybe it does not exist within your realm, Brad, but your thoughts on a single patient identifier and how that single patient identifier, I mean, many of us are passionate about that. I have been, for years, and just wanted to find out what your thoughts are about that and how that might help alternative models.
Yeah, I have not been close to our internal discussions around those kind of topics, but obviously being able to connect different sources of data together is really important. I know from my private sector experience before I got to government, how important that was and how hard it could be to match different kinds of data sources. So I think, anything we can do either in the private sector or as the government to help facilitate that with appropriate privacy concerns and things like that taken into account, I think is really important, but I haven't been super close to those specific conversations.
Well, great. I think we are at the end of our discussion. It's when we're I don't know if we're lucky or what exactly it is, but going through something of this seismic change, Brad, teaches us a lot. And if we look at it as a point of opportunity and things of everything that we've accomplished really well, and always opportunities for things that we could have done better. I think the amount of accomplishments that you and this administration or at least the healthcare piece of it has done a great job. And I think you've planted the groundwork for a lot of things moving forward. And what's amazing is, it's going to continue, as you said, now that we do have a vaccine, the distribution of that vaccine is going to be a significant undertaking from a distribution perspective and from sourcing, and it's got a specific, with the temperature of it, I think also it's going to require some complexities, but also identifying those patients, like you said, getting it out to the nursing home, making sure that we identify them. And then it's a 2-dose, I believe, vaccine is the one that's been approved. So you're going to require the first dose and then another dose after, I believe, a few weeks. So it will continue the coordination and what you put together in terms of the private and public sector working together for the success. So I think we are at the end of our time. Do you have any sort of comments to end our conversation, Brad?
No, I mean, I guess the last thing I would say is I think, in the kind of season that we just came out of, a lot of these things can feel very partisan at times. But I think when you look at the work, whether it's on the COVID response or whether it's the work we're doing around value-based care, I just think there's a tremendous amount of bipartisanship that exists around those issues and the actual things that you would do. And so my hope is that as we come out of this political atmosphere, that we can focus on those commonalities and thinking about how to build on the great work that's been done and a lot of the things that maybe we could do better or different as we go forward. So thank you so much for having me and the time this afternoon.
Oh, it's my pleasure. But you said something as I end this conversation. I really thought about it. We were on calls with your office and HHS and the secretary throughout this entire endeavor. And it was a group of about 30 to 50 CEOs. And I would tell you, in all of our discussions and to the group, no one ever brought partisanship. No one thought about this in any way, shape, or form from a political perspective. I think healthcare stayed very bipartisan, and no one thought which side of the aisle are you. We had a problem to fix. whether it was identifying patients, getting PPE, as you mentioned, identifying where the next breakout's going to be, where the contact tracing is. We made available to a lot of organizations our entire single patient identifier to be able to give it to everyone. You know, we kind of created 150 million people we already identified in our organization at Cotiviti, but what we did is we didn't care about anything. We just wanted to make sure that the information got out there, and every single organization did that. So I think this was a good moment for us to fight this. And there's definitely a lot of lessons learned, and hopefully this will accelerate alternative models moving forward. I can't thank you enough again, I'll say, for your service, Brad. I really appreciate it. And thank you for your thoughts. And for everyone, I just hope that you have a great end of the day. And I hope you enjoyed our discussion about the future of alternative care models and alternative payment models in healthcare. Thank you.